Hello, everyone, and welcome to today's webinar, Challenges in TB Care for Migrants. My name is Rajitha Bavaraju, and I'm the Deputy Director for the Global Tuberculosis Institute. Before we get started, I'd like to just talk a little bit about a few housekeeping items. If you're calling in today, so you're listening to the audio by telephone, please make sure that your phone remains on mute. Please never put the call on hold, or this will actually disrupt the webinar audio and we'll have to remove that line from the webinar. Also, all questions and comments today will be taken via the chat box. Please note that if you put in a question, and your questions are welcome at any time, that you direct them towards all of the panelists and the speakers so that we can all make note of them. And please also note that we're recording this webinar for future viewing. So if you have colleagues who were not able to register today, this will be available later. And finally, we're not providing any continuing education credits for this event. The speaker for today's talk is Liliana Garcia, who is the Director of International Projects and Emerging Issues for Migrant Clinicians Network, also known as MCN. DEL has worked for over 30 years to meet the healthcare needs of migrant workers and other underserved mobile populations. With expertise in reproductive health, access to primary care, chronic care management, and infectious disease control and prevention, including vaccine-preventable disease, DEL is responsible for the development of new projects within MCN. She's responsible for the design and management of MCN's health network, a global system of bridge case management to provide continuity of care and health records transfer across national and international borders for migrants diagnosed with all health access needs. On a more personal note, I've grown to know DEL over the years, and she's been a great leader domestically and globally in her field, and her passion for all migrant groups is apparent. We are fortunate to have her expertise today. DEL, I'm turning the program over to you.
Rajita, thank you. What kind words. I really appreciate it. And you're right, you know, migrants and migration health has been an issue near and dear to my heart for many, many years, and I'm really committed and grateful also for the colleagues that I've been able to meet over the years and that we've been able to work together, because it's made the work so much more fun and, and so much more successful. So let's go ahead and start, because I think that there's many issues that we want to discuss. And in an hour, we're only going to give mostly a surface view of some of these without being able to go greatly in depth. But I was hoping that we would at least take a minute to understand that all of our efforts around TB control, management, treatment, diagnoses do move the needle forward, and that we're trying to make all of those innovations successful. I believe that for migrants and those who migrate for purposes of employment or family unification or safety, those particular solutions may not be as fully successful as we would hope. And I offer this example as a case in point when we're starting to look at the intersection of TB and migration. Our case would be of a Guatemalan individual who was diagnosed with TB infection at the age of 36. He's moved 4 times during the course of the last 9 months. Now, evidence that the policy of using 3-HP or 4 months of RIF needs to change everywhere for the treatment of TB infection is really demonstrated by a case like this. That wonderful advantage that has been put in place by looking at shorter treatments then really makes it still not usable for a group that's on the move. And so this is what I mean by that we need to look at all of our innovations and think about then their application for migrant populations. And certainly the issue of concern is globalization, and that as people move and as the world becomes more unified and more at one, the absence of shared policies around how we will care for people really do make our work even more difficult. And I think part of what happens is that the argument gets dominated by those countries who are looking at a large net immigration, that they are looking at their resources, they're trying to make statements about what is going to be available and that those resources should be available for standing residents first. And, you know, that argument does not take into account what is happening to countries that are losing their populations, and so that the net emigration of individuals who are leaving and what that means in terms of a brain trust or future capacity to respond to so many things, and public health among them, then means that the conversation is really off balance. That if we only allow it to be dominated by those who are currently receiving many immigrants, then we are not allowing those countries that are struggling with the loss of population through emigration to contribute to the dialogue. And I think most of this is as a result of, what I call the recent story of migration, because I think if you look at migration, it's centuries old. But if we look within this last century, I think improved transportation and communication, the fact that the world economy is really growing, even though many levels of population are not advantaged by this growth of the world economy, we are seeing some movement up, even at those levels of extreme poverty. But what's clear is that the evidence around social inequality as it's increasing becomes more evident. So that even as we see some improvements in people's ability to live in their communities, they are able to also witness how much better other communities are doing than they are. And so the ease of movement that we now have, although it's somewhat more restricted than it was, but the speed with which people can move then means that when you see those inequalities and you see the economic growth elsewhere, the ability to make the decision to move on is much easier. And I think the rapid dissemination of information now also is what is provoking a lot of the movement that we have going on to particular areas. Because what we know about migration is that individuals go to where they have community members or family members, or at least have heard that this is a place that will be receptive to them. For example, I've been working down at the border of South Texas, and we've had a number of immigrants who've been granted the ability to enter while they argue their asylum case, who are from the Congo. And they have heard that a respite center in Bridgeport, Connecticut is still open, and that they have received a number of individuals from the Congo. And how that information has passed from Connecticut down to south of the U.S.-Mexico border so that those who are attempting the transit understand is really a remarkable representation of how rapidly information can be disseminated. And I think we also need to look at the volume of people moving and how that volume has increased, even in really recent years. So that if in 1990, what we were looking at is 155 million people who were living outside of their country of birth, then just by 2005, that number had increased to 195 million international migrants, which would then mean that it's, 3% of the global population was not living in their country of origin. In 2012, that moved to 214 million international migrants, and then the year for which we have the most recent data, 2017, it's 258 million approximately international migrants. And what that would mean is that if we just looked at that population, they would constitute the 5th largest country in the world, behind all, Brazil and others, and ahead of many that we think are large and having to deal with a great burden of disease and an effort to put their healthcare system in order. And so this 5th largest country is present but on the move. And I think part of what makes this conversation difficult is the terminology. And so I would ask you, we have a poll question, and I believe it's in the lower corner of the screen. I'm not quite sure how you respond to it. But what I need to just, put out is say, how many of you use the terms? Do you use the term migrant, immigrant, and refugee interchangeably in your conversation? Because I think when we are trying to have a dialogue and an understanding of the services that we're trying to provide, we get caught up both in the reality of what is in front of us in terms of individuals who are moving, and then the political conversation about what each of these terms can mean for access to care by virtue of their application for visa and all of the other elements that we're going to talk about, where they will at least be granted some access, albeit very short term and not very deep. So I don't know, Shweta, if we've been able to get a little bit of a read.
Sorry, the polling is a little bit challenging. I'm not able to pull it up.
Okay. Well, then let's just keep that in mind as we move forward. Is, you know, that I ask you to consider in your own conversations internally to your systems, and then externally as we're trying to speak with groups of colleagues or in political settings, how these terms are used. Because I think really what we need to understand is that we're talking about migration, and it's any movement by hundreds of humans from one location to another, certainly often over long distances, but it can be a very short move that moves them from one jurisdiction for the receipt of services to another jurisdiction where there is not then the shared communication. And it can be a single person or it can be in very large groups. And so that whole combination of issues then is it's the movement of human beings from one locality to another, short and long distances, alone and in large groups, that makes the conversation sort of difficult to get our arms around. And I think part of what is also difficult in this broader conversation is a discussion about population movement and the fact that we have voluntary migration, those who see the need and make the decision themselves to stand up in their alone or in their family or in their community and move to another region or another country or beyond. And then we have the entire issue of involuntary migration, which includes trafficking, which is such an enormous problem globally, and where we then see a difficulty in entering that population and trying to make inroads about how we can best serve those individuals, particularly for something like TB. In addition to people moving voluntarily and involuntarily, then there's the whole idea of anticipatory. And that means that they've put in place an orderly plan to leave the point of origin. And when we say orderly plan, it may not be the plan that we would consider, but that they had done it with some degree of planning for themselves. And I offer this as an example. I worked with a woman from Guatemala who had come across the U.S.-Mexico border and had been detained, and she was had been diagnosed with TB, and we were working to help her stay in treatment even as she was being returned to Guatemala. And I was talking to her about her plan to come to the United States, and her entire plan was that her son had come to the U.S., and she had remained in Guatemala, and she had stopped hearing from him, and she had decided to collect money from friends and walk from Guatemala to the United States in search of her son somewhere in the U.S. Not the kind of plan that I would consider really full, but this was the reason for her movement, and this was the way that she had organized it. There's generally a case of some resources, albeit limited, that are intact, and she did have some. And when you talk about destinations clearly chosen, the USA is a destination. She chose it certainly, but really the width and breadth of that landmass is such that I think it's really difficult. But people have an idea where they would like to go. And then we have the individuals who arrive in a really acute state, and they're escaping a major crisis. They have few resources. Generally, they're arriving in the state of shock. And they are dependent on the receiving community for assistance for a very long time. The trauma that's experienced does not allow them to kick in many ways, and where they are held and received is without the kinds of supports that would make it an easier transition. But I think a further distinction in human migration that we need to consider, and the point at which I believe the conversation really gets stuck, is the idea of those who arrive in a regular state. They've applied for a visa, they have valid recognition to cross an international border, their movement has been recognized, regulated by an international convention, and they are then granted access to the location that they are interested in arriving to. But I think we mostly get stuck in the entire issue of those who arrive in an unofficial state. Those who are without documentation, have not applied for a visa, arrive at a particular border, international border, and attempt to enter either by declaring themselves or occultly, but they do come without the benefit of a visa. The migrant status of individuals then, I think, is a critical issue of the conversation. Because certainly in the United States and in most countries, TB, identification, treatment, those services are a government effort. And so in the U.S., I think it's really relevant that the same government that's trying to encourage individuals to step forward and receive the healthcare services that they need is the same government that is trying to root them out, detain them, and return them. And so individuals are really clear that they cannot, in many cases, trust what's in front of them, because what's in front of them is a part of an organized element that's trying to upend their lives. And I think that is one of the places that we need to focus a lot of attention. And I think even in the U.S., you know, when we say, well, those individuals who are deeply invested in public health do not care about anyone's immigration status. And I would ask everybody to look broadly at everyone who is employed in those settings, because, for example, in the U.S., in one of the western states, we had an individual present to a health department where the general policy was not to report, and yet there was a woman who was sitting at the front desk. She was not part of what was considered the healthcare team, but she was the first person to greet this individual and felt that it was her duty to be in communication with ICE. And so she did call and report the presence of this individual, and on his departure was detained and removed. So it is certainly a governmental function that we're trying to make sure is effective, that is certainly populated and staffed by individuals who care deeply and are working hard, but it is also part of a larger organization, the government, where there are many responsibilities who do not share, and individuals in those departments who do not share the same focus and the same commitment. And I think what's true in the United States is that we need to understand that public health and the entire public health system is the result of immigration, and immigration to Ellis Island, where there were the arrival of a huge number of individuals. And so they were trying to make sure that what was coming into the country did not bring with, those coming into the country did not bring with them then many communicable diseases. You know, we talk about individuals arriving at the lower level of the building and then being required to walk up an enormous staircase to arrive to the central parlor. And those who arrived at the top of the stairs with labored breath were then had a check mark put on their back with chalk so that they could be further evaluated for tuberculosis. And interestingly, in the United States, I think there's a tendency to believe that the migration is, you know, sort of unusual, and it has not been going on for very long, and people are arriving from outside of the country now in numbers that we have never seen. And that's not true. The country has always had a wide open West. There were many efforts to invite immigration. Yes.
We're seeing some squares in between the slides. Are you able to reshare it again?
Let me do that. Is that any better?
Yeah, it's better now. Thank you.
I apologize. I didn't realize that that was happening. I was not seeing them on my side.
Thank you.
So migration in the U.S. is a long and historied part of the construction of the country. And, you know, so I think What's also true in the U.S. is that we are a relatively young country. I mean, I think I was in Moscow for like the 800th anniversary, and we have no perspective of what it means to be a country that old. And there was an enormous expanse of open land. Even now, there are a lot of open spaces that are not well populated, considered frontier. And it created a mentality of unencumbered mobility, that people should be able to move around wherever they needed to so that they could seek opportunity. And then certainly because agriculture has played such a huge role in the U.S. economy, it resulted in an enormous amount of migration as well. And we do know that in World War II, when most of the men of military age left the country or were enlisted, then a number of men from Mexico and the Caribbean were invited to come and work. When the war was over and those men returned, then of course they were all gathered up and returned to their country. But they had come at the invitation of the U.S. government. And so what we're talking about then really is mobility and the ease with which people can become movers, or the requirements of the need to move, that they go to a different house at the end of a period because the rent is cheaper or because they've lost their capacity to stay in that particular housing situation and are moving in with another group of family members. They're living in different countries, states, regions. They're moving abroad. And then the other piece, however, of individuals who are mobile is that they are moving within and between central cities and suburbs and non-metropolitan areas, rural areas within the United States, and then across the world. And so the effect of that movement, of that migration, can be very similar because of the disconnect that it creates for those individuals with the systems that they had been reliant on for health and other services. So when we think about migration today, then certainly we hear of individuals who are fleeing, and so they're moving for safety and security, those who are looking for an improved economic future. I think the rising number of individuals who are migrating for reasons of climate change, but we also have folks who move because of education, looking for housing and health care. And when I talk about migration today, I think we all need to reflect on our own mobility, because in most groups, when I'm speaking to an audience that's in front of me, and I ask, how many of you moved for school? And there's a raising of hands. And how many of you moved for professional opportunities? And there's another raising of hands. And those who moved for an economic opportunity, just a better job, there's another raising of hands. So we ourselves have done a great deal of migrating in our own sphere, and it is our understanding of how to navigate new spheres that has made us successful in those areas, either because we had the economic resources or the language or the social network or just the experience that makes us competent to do that. And we need to consider that there are many millions of people moving in the world who do not possess those characteristics. And so for them, it is not as successful, and as an example, as it has been for us. And so migration today, then, as we're looking at all of this, is that, international migration is just huge. Tens of millions of people are moving annually, and that has become the norm. Even though when you look at how public health is set up, it is really geographically static, that it is catchment areas or districts or cities or counties or states, and that those services are issued by that government for that geographic region and does not take into account the public health implications of people moving through, nor have they in many cases created a response. And I think it's still treated as an aberration in the U.S. and in many countries, even though I think more so in the U.S. than elsewhere. And so what is certainly true, has been true in this country and is true in other countries, is that there's been very little concern about the health of the person emigrating from what is considered first world or developed countries, despite their capacity for disease. And I think the impact of migrants who are returning to low-income countries from these countries with communicable disease is starting to receive greater attention. For example, if you look in Mexico at HIV, then what you see is, besides men who have sex with men, the largest population affected are those individuals who themselves or whose partner migrated to the United States. And so, you know, this is true. I'm showing you what is true in the United States, and I'm sure other countries have maps where they can show where people are arriving, and there are the traditional states like California and Texas and New York. But we're also seeing many more individuals coming up through the Midwest to work in large penned animals, to work in chicken plants in the South in Georgia, to work in tobacco in North Carolina and Kentucky. And so what had been traditional locations to receive individuals has really changed. And so refugee arrivals followed where those communities had already established themselves. And as they were coming in, they then sought communities similar to themselves. Or we have seen, for example, in Colorado, that the arrival of a refugee population displaced the long-standing migrant population. For decades, Mexican migrants came to Colorado for harvest, and with refugees coming from Somalia, who had already available to them a work permit, those jobs were then taken away from Mexican migrants and given to Somali refugees because they did not have the added concern of working without permission. And so we saw a shift in long-standing migration patterns as a result. And frequently when we're talking about migration and the delivery of health services and looking at something like TB, we say, well, we want to do it, you know, health equity is critical. And in the definitions of health equity, it's the absence of systemic disparities. Certainly, we would love for systems to be evaluated and reconstructed in such a way that did not allow and perpetuate disparities. But part of the struggle that I have is the second element of the definition, which is the absence of avoidable and remediable differences. And with a definition like this, we have the tendency to put the onus of avoidable and remediable on the person themselves who's experiencing the disparity. And the reality is that they do not have the possibility to do that. We've all looked at this particular graphic on a number of presentations in terms of the difference between equality and equity, that certainly everything is available, and what we do to make it possible for people to access that is really different if we're looking from a perspective of everybody has an equal opportunity to get there versus we make exceptional efforts to assist those who have less ability through their current circumstances to reach the level that we would like for everyone to have. And I think this becomes very difficult because we forever are being told that it's all a cost benefit. You know, the conversation is around money, and not to say that funding is not important, but over the years, what we continue to be told is that we need to be able to do more with less. And I think we hit a plateau of less below which we really cannot fall and be successful in what it is that we're trying to do. And it's been wonderful to see the gains that have been made in global funding around TB, but we all know that there needs to be much greater contributions across the world if we're going to be successful. And I think with migration, it presents both then vulnerabilities and opportunities that while we as caregivers, as service providers are working very hard to drive down the vulnerabilities of what our individuals that we are caring for are experiencing, they are concerned with really pursuing those opportunities that are going to make their life more livable. And so while we may see them as in need, they see themselves in many cases as capable, and they don't share that same perspective. And so we can be at cross purposes with those individuals that we want to serve. And I offer an example of a gentleman who'd come, he needed TB treatment, he was in a Midwestern state. I worked with a nurse from their health department. She pulled out all the stops so that he could be enrolled in their treatment program within days of my having contacted her. And from one Friday to the following Monday, this gentleman decided to leave the state and go elsewhere. And when I called her on Monday to inform her of his movement, she was so angry that she had made all this effort and that he had not appreciated her work, that her statement to me was, "Don't ever call me again." And I understand the effort that went into this and the fact that you know, she put so much personal concern into it. But the individual had their own desire to be successful, and while it certainly was going to need to include TB treatment, it wasn't dominated by that. So when we get talking about equality versus equity, then we really need to understand that in the equity, it must be driven by the person who is requiring the treatment or the access, that they get to define for us how it is that we need to roll out these systems and these services so that then they can employ them and deploy them to the best end for themselves. And I think that this is generally difficult because the conversation gets stuck elsewhere. I was writing an article and I wrote the word underserved in the narrative, and the word processing program changed it to undeserved. And I think that that is the biggest conflict that we have now, that many decisions about services being delivered and being available are based on whether or not we believe the individuals deserve access and services. And that those choices then can be the result of racism and our own sense of not wanting those who are different than ourselves to be present. And it creates an enormous amount of stigma that the individuals are experiencing, that they then begin to impose on themselves frequently, that they are unable to define what could be the source of the negative reception that they're receiving, that they see their humanity, and it's important for us to see their humanity. And so I think when we start looking at our work, we need to look at the behavior and the practices and the values that we bring to bear, understand that our social circumstances and our social history impinge on all of that, that we have customs as other groups have customs, and we can focus on how different their customs are than ours, or we can really understand that we come to our current circumstance with potentially customs that are paired and those that are not. And then I think it's important for us to look at our systems. If you come from a part of the country, or part of the world, excuse me, where if you need health services, you arrive in the morning, you queue, and you remain until you are seen, it's very difficult to come to a place where the system requires that you make an appointment 3 months out, that you be on time, and that if you're 15 minutes late, you will then lose your appointment and you have to start all over again. There's also, I think, the work that professionals play in how it is viewed. You know, the systems where we looked at the division of the clinical team being that doctors and advanced practitioners were the ones that decided how things were done, really didn't take advantage of the professionalism that came into the clinical team from individuals like community health workers and outreach workers and others who could serve as translators, cultural translators and language translators to the population we were trying to serve. And when we look at art, we see a great expression of the understanding of what is occurring in people's lives and why what is happening to them. And I think if we took a moment to evaluate that and examine that, we would see that there's a decision about how they've come to this place that could deeply affect how effective we would be in reaching them. And then I think there's certainly religion, and we can get stuck in religion and believe that religious beliefs, spiritual beliefs in some way are in conflict, and you know, people with different spiritual beliefs are unreachable in many cases. And I think I offer as an example frequently the woman from, Haiti who had TB. And she was asked, what do you believe is the cause of your TB? And she said that she'd been affected by the evil eye. And so then the clinician said, well, but why is it that you take your treatment? And she was sort of patted him and she said, you don't understand complexity. I know what gave it to me, and I understand what I'm going to need to do to make it go away. So when we talk about mobile populations, where they are and where they're going to, and where we are in the course of that movement, are a very huge and rich mix of perspectives and needs. We can have individuals as they are leaving their community, as they are transiting through our communities en route elsewhere, as they are returning to their country of origin, either voluntarily or involuntarily. And so if we're looking at occasions where individuals would be vulnerable to TB, we have multiple places. It's a moving jump rope that the person is going to jump into, and it's going to be difficult and important for us to assess where they are. And so when we talk about vulnerabilities then and how we support migrants in understanding and addressing the TB vulnerability, we need a case in point of how broad that field really is. And so I offer this case study that we looked at in terms of contact investigation. This went on in mid-Atlantic state in the U.S. A young man who came to a health center for his first visit in August of 2004. He'd had 4 weeks of cough and night sweats and fever and decreased appetite. He'd certainly lost a significant amount of weight. And he'd moved to the U.S. the year before, and he was now working in a stone fabrication factory, but has no history of smoking or drinking, drugs. He's single, but he's living in a house with 6 unrelated individuals. So he's in a factory where there's the need to control for dust, and he's living with 6 individuals in one setting, which might not have provided significant or sufficient space for each person. And so there was no history then of chronic illness or hospitalizations, was not taking any medication. But when they did the family history, then he reported that his mother had died of unknown causes when he was a child. He did have 6 siblings, all alive and in good health. But his father was known to be alcoholic, and he had died in 2002 of active pulmonary TB. And so when they examined him, here you have a thin, ill male with respiratory distress. They were listening to the lungs. There was no Hep C. He was HIV negative. And, the PPD was at that range of 10 milliliters, which, can create some discussion about what it actually implies. But with x-rays, then they could see extensive infiltrates in both lungs, pleural thickening, and that the cavities were changing. And so, fortunately, this man was seen at a community health center where the clinician had experience with TB and TB treatment, and so he was admitted to a negative pressure room. They collected the sputums, and they started this set of medications in the hospital. And they, they saw that the smears had loaded with AFB, and so they immediately turned on day 2 to the 4-drug regimen for TB. And then by day 3, they were able to take cultures. They all remained negative, and so the patient was discharged to his home. And so he was homebound. He had to wear a mask, and the state health department notified and made a visit to the patient in the hospital so that he would start on DOT the next day, and when he was discharged was on the 4 drugs. But within a week, there was no fever, no distress, his appetite had improved, and the cultures returned at 5 weeks to say that he was sensitive to the meds that had been initiated. Because this patient presented with with capillary lung disease and had a weight, below the 10% of normal, and he had remained smear positive for 8 weeks, then his continuation phase was extended from 18 for a total of 9 months of therapy. Because this man did come to a health center as opposed to presenting at an emergency room, which frequently happens for individuals who are in a moment of health crisis, the costs for this intervention were really much lower than they might have been elsewhere. The initial evaluation at the health center department was, a little over $400. The hospitalization, while high at $20,000, did include medications, and then they were looking at continuity of care through the health department. And so the total cost of diagnosing and treating this case of TB was $30,526, which sounds like an enormous amount of money, I understand, particularly when you look at multiple parts of the world. But then we think about the contact investigation that was conducted in concentric circles through home, visitors, work, social contacts, and then those individuals who had contact with him at the hospital and the community health center. And with that investigation, they found that the 6 individuals with whom he lived were all positive, that 4 of the 5 frequent visitors were positive, and that in this work environment, of those individuals who were in the same shift but different areas, meaning that they used the same lunchroom, the same break space, that 70% of those individuals were positive. And then on different shifts but same day and different days, another 51% of those individuals were positive, and no one at the hospital or the health center was shown to be positive. So we have a total of 317 individuals that were evaluated, and of them 182 were positive, which is, over 57%. And you would have expected to see a standard positivity rate for this group of individuals not having had contact with the case to be 15 to 25%. So we're looking at a baseline positive rate of about 48 to 79. So this one active case of TB infected potentially 103 to 134 other individuals. And when we look at what has been prevented and what it might have cost to treat all of these other individuals who were infected or potentially infected by this individual, then we really need to look at this as a tremendous cost savings. And I think that there's a lot of missed opportunities to be able to deal with individuals who may have TB disease, but who would not present at the state that this gentleman did. That we have to speak among ourselves as professionals when we look at patients who come to us, that we have to have that conversation. That when we look at EHRs now, family history is very difficult to view in its totality. You certainly have an area where you can collect those data, but to be able to pull it up to make some kind of historical evaluation is much harder. And certainly the person-to-person conversation across health service groups is also difficult in many locations. To have health center staff talk to health department clinicians is often very difficult. And then deep conversations with individuals who come in to be evaluated to try and understand better where they are coming from, with the fact that they are recently arriving from elsewhere, that they have in mind that they will be leaving this area and going elsewhere. And so as we're trying to look at diagnosis and treatment and completion of treatment, we have to contemplate the missed opportunities that might be directly in front of us. So, the course of action. I mean, there are multiple roads that we can go on, and there's really a divide. But it does require that we contemplate issues like cultural knowledge. And that doesn't mean, the cultural competency is really not the issue of concern. To say that we could be competent in all cultural issues is really an exaggeration of what we are capable of. But I think if we can familiarize ourselves with the populations that we're serving, with the individuals that are arriving to be in front of us and requiring care, study belief systems, look at behavior, and speak to folks from the different groups who are present, then we can learn a great deal. I think the sensitivity, the humility that comes from knowing that there are cultural differences that exist without really assigning a value to those differences of one being better or lesser than another will then make us a great deal more successful. So I think what we're trying to always achieve, and we're hearing this a great deal more, is that we want it to be patient-centered. It does not require exhaustive knowledge, but it does require an openness, a willing to be inquisitive, and to recognize the individuality of each person in front of us. And that we reflect on our own ability for there to be some humility in how we address others. You know, I lived in Brazil for a long period of time, but it was many, many years ago. For me to say that I now understand how Brazil works would be completely untrue, even though I can communicate in Portuguese. That experience is long gone, and I've not had the same governmental changes and social changes that are now being, that people are now facing. And so I need to say I'm open and interested, but not all-knowing. And then I think we need to allow for collaboration and negotiation with our patients in terms of having them be an active partner in planning how something will be addressed. And this means that in terms of treatment, describing what is going on, having them understand that they will, you know, feel better with time. Do they feel like even as they are not having the same symptoms that they can continue to take the medicine, or should they start to feel uncomfortable in a different way with an effect of the medicines? Do they feel like they can come back and talk to you and you can negotiate to see how you move forward? And so I think it's always a benefit to us when we can engage in that conversation in really different ways. And so when we're initiating it, I think it's always a benefit in our work to say, what do you think caused your illness? Or do you have an explanation for why it started when it did? What have you done to treat this? Because many people may have turned to traditional treatments, to herbs, they have turned to prayer, they have turned to other spiritual interventions, and I don't think they need to be discounted. I think that we can congratulate the individual for making that effort, for understanding that they can take an action, and that you would like to take an additional action, you know, for you on their behalf. So, because then you can talk about, you know, what does the sickness do to you? Do you know how it works internally? And that helps them then have you ask anyone else to help you so that you can understand the benefit of what kind of advice they have gotten. It may not have been wholly accurate, but at least you know that they have turned to other people and that they are open to communication with others and see others as competent, which is sometimes a conflict, but we do want them to really see that there can be sources of information and you want to be a source of information. And then saying, you know, what kind of treatment do you think you should receive? So that in addition to, I believe that I should receive a great deal of prayer, and you can say, great, I think that, do you have someone with whom you pray? Do you have a group that will pray with you? I'm grateful that you have that, and I would like to add to your process these medications to enhance the benefit of the prayer that in which you're engaged. All of these things require a negotiation that take a lot of time, and I know for many professionals that's very difficult, and that the person who's standing in front of you may not be there tomorrow. And so then there's always the urgency of how to start the conversation, what elements of the conversation to have, and what to do next. And so what it allows me to do then is speak some to the response that MCN has engaged in the last 25 years. In 1995, actually, we participated in a funding challenge to look at case management of migrant patients in the U.S. And while we were unsuccessful in winning the funding, we were very successful in realizing our idea of how it is that you could maintain someone in care even as they are moving. And so at that point, we created a project called TBNet, which has now been assumed by Health Network, because it's no longer just devoted to TB. We are engaged in helping people remain in care regardless of the healthcare issue. And what happens is that they are enrolled by a clinician who is initiating their treatment or continuing their treatment and is fearful that they will be lost. And so they connect them to us. We have toll-free access. We have bilingual staff, but we also use a translation line so that we can be as careful in our communications with the individuals as possible. We store and transfer their medical records so that the next place they go for care will have the benefit of as much information as we can possibly provide them. We help them coordinate the care in the next place because they may be unfamiliar, understand the processes that they need to engage in. And we're always involved in ongoing communication with them where we can educate them more about what's happening to them until their treatment is continued or until they have reached a stable place in their mobility and they don't require our assistance anymore. And in that moment, then we can say, great, you don't need to hear from us again. Should you decide to move, this is our number, call us, and we will help you at that point. And what we like to show folks then is that between 2005 and 2015, because we were changing databases and trying to look at how we were going to capture those data from the perspective of being able to do case management actively globally, we are able to see that we enrolled almost 11,500 cases in Health Network, and that the breakup of those individual healthcare issues, it came along these lines, where a majority of it was TB, but we were also looking at cancer and diabetes, general health, and we also were working with women who were not sick, they were just pregnant. And so when we look at the TB element of that, there were almost 2,000 for whom treatment was recommended. 26 had multi-drug resistant, 65 were resistant to at least one drug, and 34 in that period are deceased. And what I will tell you is that a majority of those individuals who died did not die from their disease process, but died from returning to their country of origin, where then they were killed, or died from other accidents or illnesses. And so we actively followed the 1,962 cases. We lost 189 of those cases, so we did have a 10% loss to follow-up rate, and 105 refused treatment once they got elsewhere, where we were not able to have direct communication with them, and once they were refused, we were not able to intervene further. But what that means is that we had, 1,600 that completed treatment for an 85% treatment completion rate. And it breaks down this way when we look at active TB cases. In that period, we had 243 active TB and for whom treatment was recommended. 2 died. 15 at the time that these data were originally calculated continued treatment, and then 3 for whom treatment was not available. So we followed the 223. We did lose 7 to follow-up. 7 refused treatment. But it means that in this 1 year, in 2015, the year for which these data were calculated, we had a treatment completion rate of 93, almost 94%. And when you look at treatment completion rates in static populations, for example, the population within the United States, which I believe is at 87% right now, we believe that we are handling more cases than most states in the country, and certainly more than many countries, that they are moving globally, that they are transiting international borders, and yet our capacity to maintain them and support them in care is evident, so that we can have a really strong completion rate. And so what this means then is, from our perspective, migration need never be an impediment to health. That even though people are moving, there are systems and processes that we can look for that reduce the disparities that are brought about by migration. So that was what I wanted to cover today. I know that it's difficult to do questions. I don't know if any have come in to the chat box or the Q&A slot.
Del, thank you. Del, thank you so much for a really wonderful and comprehensive presentation. I think you reminded us of a lot of the concepts of why people migrate for various reasons, and how there are a number of avenues people come here, and what their needs are, and how they may be masking perhaps the treatment for TB. For many of these individuals, it's almost a need to survive. I also liked your terminology, cultural humility. I think sometimes as healthcare providers, we feel like we sort of need to know it all, and I think that knowing that cultural humility is a behavior that we should all be thinking a bit about, that really we can learn. It's a two-way street. We can learn from the individuals we're treating, I think is very important as well. A couple questions came in. I don't know if we're going to have time to get to all of them, and we'll try our best to work with you to bring those in. So one of the questions is just about this idea, this concept of how you talked about people moving to areas where there's individuals who are familiar to them, there's community, there's family. And I was wondering if you could talk a little bit from a case management standpoint, how local community that's from the place where a migrant is from can be utilized in assisting with treatments, language barriers, and such. I was wondering if you could talk a little bit about that.
Well, two things go on. Certainly, we know that they may go on to a community. They report that they're going to go on to a community, like the Connecticut example that I offered, and so we can be in communication with health professionals there who then know of community health workers or other individuals in the healthcare system who have good access to that. Additionally, when we enroll individuals in Health Network, we ask them for all of the contact information they can give us. And this includes their grandmother back in Guatemala, so that while she may not speak to him or her every day, this person will call their grandmother at least once a month on Sunday. And so what we can do then is call grandma. We don't have to disclose what's going on, but we can say we were helping your grandchild, and they asked an important question about where they could get some health care, and we want to help them do that. When you speak to them next, would you ask them to call us? And interestingly, family members who are not present in the country are really devoted to trying to keep their family member healthy and in care. So we try and look at the role of the community, both in the community of origin that has remained, that was left behind, and then the community, potential community where they arrive or where they might be moving to next, to understand that they can be an incredible resource.
Great, thank you so much. And I think we have time just for one more question, so I'm going to lump in a couple here together. So somebody had asked about if somebody's leaving the country, a migrant's leaving the country, either voluntary or involuntary before completing treatment. And I think this could pertain to both treatment for active disease and maybe addressed separately for for TB infection. Do patients get their medications before they leave? What sort of arrangements are made? And I know you've talked about TBNet. Someone else mentioned Cure TB as well.
Right.
So you can talk a little bit about when people leave mid-treatment?
Right. I think if they're being removed, then that is through, the detention system. And as I understand it, Cure TB is engaged in that. When we had done it historically, we've not worked with ICE in the last 3 or 4 years. They were given some medications, frequently just about 2 weeks. I don't know if that has changed, but what we were allowed to do is contact the country of return to say they had a co-national who was coming, that this was their course of treatment, that we needed to understand what was going to be the nearest health service site for them if they were coming from this community, to whom should they present, and then we return that information to the individual so that when they arrived, they had some support, and we continued to communicate with them when they went back to their country of origin. My sense is that that's probably how it's working now. For individuals who voluntarily return, that's certainly what we're doing, is we're finding a healthcare provider that is nearest them, that can continue what's going on in terms of where they are in the arc of their treatment, and then we get that information from the clinician and feed it back to the original enrolling site so that they know the outcome of that case.
Great. Thank you so much, Del. And unfortunately, we're out of time, and I'm glad we were able to spend the bulk of the time on your extremely informative presentation. If it's okay with you, as I said, we'd love to be able to work with you to answer some of these additional questions, and we can post these on our website along with the recording. And lots of compliments have also come into to the usefulness of your presentation. We very, very much appreciate the time that you've been able to spend.
Thank you so much for inviting me.
Thank you again. Before we end today, I just want to mention that you'll be receiving a link to an evaluation for this presentation, and your feedback is really important, so please respond to that, and if you have additional questions, again, please feel free to contact us, and we'll try to get you the answers. Thank you all very, very much for joining us, and have a great weekend. Bye.